You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Welcome to the Pharmacist Podcast Network, the Precision Medicine Pharmacist, which is a podcast where science, innovation, and collaboration are redefining patient care. And for those of you who don't know my series yet, my name is Dr. Melissa Smith. I'm your Precision Medicine Pharmacist. And we are kicking off a special two-part series titled Precision Psychiatry in Practice, a pharmacist-physician collaboration. And in this series, we're going to explore how precision medicine is reshaping mental health and its treatment options, and what becomes possible when a pharmacist and a psychiatrist work together with shared clinical goals. Today's episode, The New Frontier, how pharmacists and psychiatrists are teaming up for precision mental health. And this focuses on how this collaboration began, the challenges that inspired it, the early conversations that shaped it, and the practical steps taken to bring pharmacogenomics into psychiatric care. Joining us is Saba Arshad, a clinical pharmacist, the founder of MedDNA Health, and a strong advocate for integrating pharmacogenomic testing insight into the mental health treatment space. We will also hear from Dr. Khan, a psychiatrist and clinical partner, in part 2 of this series, as we explore how their professional paths aligned to create something new. In this first episode, we will lay the foundation, examining the why behind precision psychiatry and the systems that had to evolve to support it. Let's begin by meeting Saba Arshad.
Hi, everyone. Hi, Melissa. Thank you for having me, and I'm grateful for the opportunity.
I am so excited to have you here on this podcast series because, as we know, pharmacogenomics is such a crucial tool, in my opinion, to be utilized in the psychiatric space because it really has a lot of high-level evidence that can really align with lessening treatment resistance with patients, having them go into remission more quickly because they're getting appropriate care the first time around, as opposed to having trial and error being implemented. So I'm very excited to have you just explain your journey and how you were able to get into collaboration with Dr. Khan as well. So if you don't mind, give me a brief introduction. I want you just to lay the foundations. Let me know, give our listeners and our audience a peek into how you became a psychiatric pharmacist utilizing pharmacogenomic testing.
Sure. I'll try to keep it brief. My name is Saba Arshad. I am an Irish-born Pakistani citizen. I am a clinical pharmacist, founder of MedDNA Health, and we focus more on pharmacogenomic testing. I am also, I work part-time at a hormone compounding pharmacy, and I can't tell you how much that has shaped a lot of things and a lot of things that I didn't take into account earlier. I'm also a board member for a local nonprofit, and we provide primary care services to people who are uninsured. We not only serve Texas, we also serve other states as well. And the last one would be I am a volunteer and ambassador for NAMI Central Texas chapter. So that probably relates to my mental health advocacy part. And from my journey, I'm thinking, where should I start? So I'll start back from when I was in pharmacy school. A lot of people ask me, why did you go into psychiatry, or why do you start with precision psychiatry? So my why started when I was in pharmacy school, Melissa. One of my loved ones in the family, they were suffering during the teenage years, because I'm a practicing Muslim, and back home, especially in our Southeast Asian community, we do not talk about mental health. We do not talk about what are the red flags that do happen with a lot of kids. At that time, I just started pharmacy school in 2008, so I didn't know a lot of things, but at the end, I did feel guilty, although there were a lot of things that I just didn't know and I couldn't handle. And unfortunately, at that time, my loved one was diagnosed with borderline personality, major depressive disorder. They were on a suicide watch. They were on, I had no idea what self-harm meant. I had no idea what kind of those marks meant and what it actually felt. But there were a lot of things, and the hardest part, Melissa, was seeing them go through those treatment protocols, because they were put on everything. They were on antidepressants, antipsychotics, mood stabilizers, and it wasn't like a trial of you would start with one or two medications. They were like bombarded with like 8 to 10 medications, and then unfortunately to counter those side effects, there were more medications added, and that just
Yes.
took them off. It was a lot of emotional instability. Everything. I think the quality of life, it just tremendously declined. Their school and everything else was impacted tremendously. But that took a lot of time. And eventually, when we got them tested, that was probably 5 to 6 years back. And that has helped. And a lot of the credit does go to the clinical psychologist on the team and the psychiatrist, that they were willing to work with whatever data we had. And we were able to figure out what medications would work best. And a lot of the side effects that my loved one was having, it made a lot of sense why it did not work. And they were having a lot of brain fog and other emotional issues that do come with that, and especially weight gain and insomnia. That was a biggest one that did come up. So a lot of these things, then eventually we were able to figure that part out. And now I'm so happy to say that they are thriving and they are medication free. So it was a long journey. It was about 16 years. It wasn't an easy journey, and they did work on it. But that's what I tell a lot of my patients. Yeah, you can start with the medication, but unless you try to figure out what is happening inside, your traumas, your other things that keep you up at night, unless we start working on this, the medication is just going to support you. It's not just going to eliminate whatever happened, unfortunately, in your past. So those were few things that I believe have strongly shaped my perspective, and that's what. And then I did work at chain pharmacies, and during COVID times, we were also vaccinating, right? So, and we were vaccinating, especially in Texas, we were vaccinating kids who were older, who were 12 years and above. And Melissa, even till date, I cannot forget the faces of those sweet children, because I would, whenever we used to vaccinate them, I could see the same self-harm marks in those kids. And those were
Oh,
all teenager girls and boys. And this was the time when people actually started um, kind of realizing how mental health was impacted. It wasn't something that just came out of COVID. There were a lot of people who were suffering really bad. COVID was just a reason that kind of pushed people to actually kind of realize that this was happening in their community, with their kids, in their families. And the last thing that I think that kind of also shaped me or helped me to become what I am today is as a born graduate pharmacist, there are like a couple of different licensing steps you have to take, and there are a certain number of hours you have to do. And I was fortunate enough to work at a specialty pharmacy back in Boston before I moved to Texas. And now I think back, and I think I was just intentionally pushed into these spaces by God, because I believe everything does happen for a reason. And I only worked with people who were used to manage medication for people who had HIV, hepatitis C, alcohol and abuse disorder. So those were a lot of things, and everything does gravitate to mental health at the end of the day. So that, I think, all of those experiences, counseling patients at other pharmacies, looking at their side effects, so everything shaped what I have become today.
that is a tremendous story, and it really resonates with me, as I can tell that so many points, critical points within your career, psychiatry really was something that was always present, that you observed, and that you just at a very visceral level felt for these patients, and it really has called to you. I totally agree with that. And it's just so interesting to me that when we think about the different areas as we practice as pharmacists, especially for like the inpatient setting in your early, I would imagine one of your clinical rotations for API or IPI rotations, you had the experience of an inpatient psychiatry rotation. I also did. And I agree with you that the amount of medications that these patients go on within the hospital setting, where you could say that it's a little bit safer environment because they're already in hospital, but the amounts that they go on is just insane. And to think about the prescribing being done just off a clinical protocol and without the proactive testing, utilizing pharmacogenomic testing, where it could be such a useful tool if it was already done for the patient. We're not having to wait for results, especially in those patient settings where multiple medications in those categories, anywhere from antidepressants, mood stabilizers, antipsychotics, being added. So for us as pharmacists, it's so important for us to have an awareness around that information and also being able to apply it. But you're also thinking outside the box when we think, you mentioned hormone replacement and just like hormonal imbalances, especially for women. That is key to balancing a lot of the mental health mood changes that can happen in perimenopause and menopause. So you are really just focusing on, in my opinion, the main precursors to how essentially people, especially women, can be developing these certain mood disorders as well. So it's not just about the genetic findings, it's about the whole picture. So I love that. And there is an interesting statistic that I was looking at before we hopped on today, and that it's concerning to see that there's such high rates of inadequate response and treatment resistance for depression medications. And it was saying that less than 50% of patients achieve adequate response in their first antidepressant trial. I mean, when you think about that, that's insane. That's such a high percentage to even think about. And then around 30% of patients meet criteria for treatment-resistant depression after multiple treatment attempts. Mm-hmm. That's crazy to me. That right there is enough to show me that clinically we need a tool to help us eliminate that from occurring with our patient populations, because the more we delay treatment for them and not finding the most adequate and appropriate treatment the first time really delays it in that space, because it's I like to say 6 to 8 weeks before we see true treatment response with the antidepressant categories. Mm-hmm. Many others take a long time to regulate out in the patient populations as well. I mean, don't you agree? I mean, I'm sure you see this a lot, even where you're practicing currently.
Yes, I totally agree with that. The same thing, patients are not just on just 3 or 4 or 5 of them. They are taking a lot of them. And even when I started working on my own on the consultant practice, and now with Dr. Khan, I just don't look at their psychiatry medications. It's whatever other medications they're taking. They could be on a statin. They could be on their blood pressure medication. They could be on maybe something for gout. It could be anything else. So that helps me to see them from a whole person perspective, not just looking at the genetics. So even with this office I want to use pharmacogenomics as another clinical decision support tool. It's not we're replacing the clinical judgment. We're still using the evidence-based guidelines we have, and then using the CPIC guidelines, and then not just the guideline part, but considering the patient as well. What are the symptoms? What is the patient willing to do as well? Because sometimes if we're just forcing the patient, they would still not stop doing it. That's the problem right now. And how I can explain it, currently we're working with a patient, and unfortunately she's on a very high dose of benzodiazepine. Now she's taking 4 milligrams 3 times a day. And the maximum, yes, and I think the maximum is 6 milligrams. It is so hard, Melissa. It's been like a couple of sessions. It is so hard to taper her off, because once she's in the menopause stage, the problem is it's so hard to make her understand, because when she thinks that she's not going to sleep, she's not going to sleep. No matter what you do, and Xanax is not the only thing she takes. She takes hydroxyzine, then she takes Benadryl, then she's on mirtazapine.
How is she awake?
Yeah.
Or not sleeping, rather. I mean, I would be knocked out for days on a combination like that. So you can see like the fact that she's built such a tolerance to the combinations of therapies through the years. I can imagine that it's treacherous to navigate the titration down off of those therapies. So
that's true. And the interesting thing to throw in the mix is like about 25% of antidepressant antipsychotics, they are metabolized by CYP2D6, and she was a poor metabolizer. Can you imagine that?
Yes. Oh, no, I know. And then when we think about the potentials for that enzyme to phenoconvert with other additional medications to be onboarded as well. I mean, CYP2D6 is the enzyme activity that we as pharmacists have to be so careful with, because it just has so many things that can really interfere, not only at the genetic standpoint, but also from the drug to drug interaction standpoint, that we need to be very highly vigilant around. So yeah, knowing that ahead of time, I mean, that spreads into other areas of her treatment as well. As you know, CYP2D6 has its hands in many medications in the pharmacogenomic space. So
that's true. That's true. It's just crazy. Yeah.
I want to ask you a question. So I want to know a little bit about how you got started at Dr. Khan's practice, kind of just your conversations, your connections, and just how you're operating right now in that space.
So it started probably 6-7 months back. So I was, it's been almost 2 years. I've been doing the consulting part. I do pharmacogenomic consultation for a lab in Houston. So I started doing that last year. Yes, around sometime last year. So with her office specifically, the good thing was they were doing GeneSight before. So that kind of helped. But the problem was because in our traditional insurance world, providers are busy, looking at patients, and they're just given a very small window, sometimes it's just 10 to 15 minutes. And unfortunately, they're not reimbursed for anything else that they do, because then they cannot put a CPT code or other codes for that stuff. So she always, and the best thing was because she was not only a psychiatrist, she also did her training in integrative psychiatry. So so that was another area that she was open to different things. And that really helped, because they were doing genes. I thought she had an idea, but there were a lot of questions because she was confused by how the lab, most of the labs, they were just color code, that this is green, you can start using it, this is yellow, and this is red.
Which infers too much, in my opinion, that it's a safe option, as opposed to this is one that a lot of times when I'm having interactions with providers and explaining the results to them, I have to reiterate to them that this is part of the puzzle. It's not the end all say all. You have to look at other factors, which I know you know, but this can be a very good starting point for a guided direction in one way or another too.
That's true. That's true. Yeah. And that, I think, eventually helped, because I think her openness and willingness to listen. So I think that was a different mindset that she had from other different people that I've usually worked with. And that started because they were doing GeneSight. I usually like using Tempus, because I've been using it for a while, and they have been honestly very consistent in the reports or everything that as compared to other labs I've used. So that's just my opinion.
I do like Tempus, especially in the psychiatric space. And when I first started doing the consulting myself, they were one of the first labs I ever used. I utilized them for one of my own family members. And yes, their comprehensiveness of the genes that are necessary, in my opinion, to be tested for psychiatry are very comprehensive, accurate, up to date. And they also are implementing some new AI type of integration, because did you know that they actually took in OneOme? So they actually acquired OneOme, which is another pharmacogenomic lab that I used for years. So I was really pleased to hear that they're still utilizing that as a comprehensive test under the umbrella of Tempus. So in case you didn't know,
that's true. Yeah,
still accessible.
That's true, and that would be exciting. I would really love to see if they add different genes that we could, help. Because when we see a patient, they have like everything, not just the psychiatry ones. They have other blood pressure medications and other ones. And because even on Tempus, we just have CYP2C9, but we don't have anything related to the warfarin response. We don't have the 4F2. We don't have the VKRC1. So that is that I would really like. That there were, because when I first started, Melissa, I had the opportunity to get my testing done through OneOme. So there are a lot of things I learned about myself that I wasn't expecting. there's usually when it comes to warfarin, let me give you an example. Like I am a CYP2C9 normal metabolizer. I am okay with CYP4F2, VKORC1, but I have a rare variant, and that's usually a SNP, which is called, I think, RS 122738, that is usually found in people of West African descent. And I
Interesting.
know anyone in our family who did belong to West Africa. So I have absolutely no idea. But yeah, I do. I'm normal for everything, but I do have that cluster. So where do I fall into those guidelines and those algorithms? So yeah, they are there.
Yeah. So much of our guideline does have a lot of different ancestries that need to be accounted for, especially for African American ancestries, Asian ancestries. There's a lot of different guidance around that. So yes, it's important to bring up as well. And my other thing I was looking up before we kind of started our talk today is you were talking about the just actionable variants to really look at. So I was looking at real world prevalence of actionable CYP2D6 and CYP2C19 phenotypes. And I was looking at a large clinical trial. This is actually coming from one of Tempus's clinical trials. Testing for cohorts to show around 65% of patients had actionable CYP2D6 and or CYP2C19 phenotypes. So if that tells you anything as far as actionability and applicability for PGX testing and its utilization, it speaks volumes. So for us, it's really important to make sure, like you said, a lot of times with providers, it's their time constraint. They're seeing the patients, actively working with them, and they really need an advocate like a pharmacist, like you and I, who are able to come in, interpret the results, provide them with clinical action plans that they can actually implement in real time. And that really should be, in my opinion, where the practice should be going. And it really is. There's more roles available to pharmacists now in that kind of a I wouldn't call us genetic specialists, but pharmacogenomic specialists, where it's applicable for us to be in those conversations and advocating for them for safe utilization of it. Because I feel like that's always the apprehension, right? Is that they feel clinically liable if they don't interpret and understand the results. And that's why I want any of our physicians, nurse practitioners who are wondering about pharmacogenomics and how to work this, that's what we are for you as your advocate, to be able to utilize it correctly, safely, and to take a burden off your plate. And I feel like when you've talked to me about your interactions with Dr. Khan, that's really what I feel like you're doing, is the medication management, right?
Yeah, that's true. And another thing, the biggest thing for the clinic was they do not want another burden on themselves. That was the big thing. So that took a while to figure out how would we schedule appointments, or how would we, without putting a lot of pressure on the office manager, on the people who are scheduling appointments. How should I take those kind of things out? Because there were unfortunately no answers for most of them. So what I did was I did a brochure. So what I do is, because I do a website, so I did design a brochure that was specific to that clinic. So whoever wants to learn more about it, they would just scan that code that takes them to my website, and they can email me. They can book a free consult and just talk to me. So that just helped me to take away a lot of things from their plate. So everything that's from scheduling,
Is that at meddnahealth.com? Is that correct?
Yes, yeah, that's correct. Yes.
I love this. This is nicely executed. I like this a lot. But it helps the patients to know just kind of some different resources, how it works, to schedule a discovery call, DNA sampling. So you're managing all of this at Dr. Khan's office. You're basically just a built-in, structured, operating business within a practice.
That's true. Yes. So I've tried to keep everything off their plate. The only thing is that the office has to do is send me any kind of lab work or any kind of previous history. So even for that, what I've done, because I use Practice Better for all of my patients. So what I did was
Me too. I really love that operating portal for us.
Yes. So what I did was I just made a folder for that office. So anytime I want something and the patient cannot provide to me, I would just email or text the office manager, and she would upload it to Practice Better. So that has really helped, because it takes a lot of time to get everything from the patient. And most of the
Oh,
patients, they,
yes.
yeah,
And if we can streamline the process in a patient compliant portal access,
yes.
that is huge. And I really love Practice Better because it's affordable for us as consultant pharmacists. They have a lot of different options to what you are paying monthly to be able to operate on that system. I love it. It's really made my interactions with my own personal clients very seamless as well. So I'm happy to hear that you're utilizing it as well.
Yeah, and I think that has helped me so many times. And another thing was, when we talk about the insurance and the liability part.
Yeah, that's a big topic.
Also, usually don't talk about that part as well, because when you were talking, because there are other, because since it's a mental health practice, there are a lot of other licensed therapists or there's a traditional Chinese doctor who comes in and does acupuncture and other kind of herb related consultations with the patients.
Right.
So there were different things that we were working on, and the only thing was I had just had to cover, the slip and fall coverage. So I was able to get it covered through my current insurance carrier. So those
Okay.
things that just in case anything happens, so the patient is not just suing the practice, and the practice takes on. So it was kind of something that did work for all of us. So these were a few things. It did take a while to come up with all of these solutions, but
Yes.
now once I started working with them, like starting with the first patient was in November. So we do just cash pay, and then there are a lot of patients who have done the gene side or they do other kind of stuff, and then
So you're able to pull in their results, interpret that for them, I would assume, yes?
yes, yeah, for most of them. Yeah, so that's what we are doing. I started in November, so we are still kind of in early initial phases. And the main thing was it wasn't like we're just going to do testing for all of the patients. We are just going to focus on a small set of population who really needs, who have been struggling not for like 6 months, have been struggling for years.
I think that's wise because it allows you to kind of get your foundation set in terms of protocols within the practice and really get the better management of those patients that are more complex. So, love that. Plus, as it becomes more and more popular and patients become more and more aware that it's available to them, I find them wanting to get it on their own and researching it on their own is becoming way more accessible now in terms of, especially because when we think about how insurance is billing for things these days, and you could literally bill for a pharmacogenomics test, you could get $1,000 bill and you could be paying $350 for it out of pocket once in your lifetime. Yeah. So it's really asinine to me how the insurance billing works as far as its implementation in the space. But for those of you who aren't aware of how you can get it billed currently, it's typically done through either certain Medicaid programs, but really primarily through Medicare. Medicare B is the primary payer on it through very specific diagnosis codes and things. And even in that space where we have polypharmacy rampant within the long-term care population, it makes a lot of sense that it would be covered there more readily. But at the same time, it's not regularly utilized in that space because a lot of the practitioners there, one, overwhelmed. They have hundreds of patients that they're seeing. Their nurses, as far as, helping with the oversight of the medication management is, overworked, overburdened. And that's where I feel like the consultant pharmacist in those spaces really should be championing this to be able to bring that information into the provider and also create their medication action plans in accordance to that. So that way, within a certain time frame, the provider, if it's introduced to them in that environment through certain recommendations from the pharmacist, the consultant pharmacist, they have I think it's 30 days to act upon it. So that is kind of more of a pressuring of using it, but still making them aware of it and having those conversations is a big deal.
And one more thing that I wanted to add was with these offices, another thing was when you get the test results, right? You have everything. You did the first session. We have their history, their supplements, whatever else they're taking, the lab.
Yeah, don't forget supplements.
Yeah, that's a big one. Now we have peptides coming. Yeah, and you have.
Oh, yes.
Yes. Yeah. So a lot of these things, when they do come in, is to basically make the report simpler and just add what are the actionable items that the patient needs right now. And if we have any recommendations, what I like to do is I like to explain why I'm recommending this change or what's the rationale behind it. So
Yeah. What does that look like? All right. So you're obviously you're counseling with the patients, I would imagine. Yes. You're having one-on-ones with them.
Yep, that's right. Yes, yeah, because virtually, yeah, it's different, but it makes a lot more difference once they're sitting right in front of me. And this
Mhm.
is what has happened because, with the testing, it does take like 14 days. No
Yeah.
matter how quick it is, now the turnaround times are getting better, but still the patient might not be available. It takes about like 2 to 4 weeks when I see the patient next time and the medication.
Start to finish.
Yeah.
Yep.
Yeah. So that's another thing with the office. And I have that flexibility that I can call Dr. Khan and ask, or maybe the office manager, what has changed? And every time, Melissa, there is a change in the medication.
Whenever it's utilized, I'm happy to hear that. That's great.
Everything has, and some of the time before I'm like compiling everything, something has changed. Either they have discontinued something.
Well,
Yeah.
a helpful thing that I've learned to make sure that the providers are, when they're doing their medical charting, that they are making note of the utilization of the PGX testing. So that way, when we do go back within the record, we can kind of quantify and create some statistical analysis around it as well. So that way, even as they see it as, it's a cost savings for them for less time management over the medication management, but also lowering the amount of times that they're having to adjust the medications for the patient and just getting better overall treatment, getting them into remission's the goal, right? So,
Yes.
yes.
Yeah, that's true because at the end of the day, we all want better patient outcomes.
Yes, that's the why. Big why for me is that I want all information being utilized to make sure that when we are having complex patients on multiple medications, that we just have all the information in front of us, because that's ultimately, it's our job to do no harm to our patients, and providers know this as well. So for us to be able to help them implement that, it is, in my opinion, crucial. It really is should be a standard of care. And in Europe, it is. The pharmacogenomic testing is more prevalent in Europe, and it's used more as a proactive method of treatment and testing early on. So in the United States, we are definitely behind with that regard, because it's just a corrupt system out there, unfortunately, when it comes to, when we think about PBMs and reimbursements for pharmacists. And then when we also think about just the amount that we pay into our insurance companies for coverage of things, and then they deny us on just, certain things that we haven't tried yet, which is absurd. It's just a difficult system to work in. But that's why the cash paying business, because it really allows us to circumvent around that, and we can actually make it more of a price conscientious experience for the patient, especially when we think about that.
That's true. That's true. And there is a very big population that is willing to pay if they know that the services that they are getting would be valuable and it would last them for a longer time. That's why in Texas, I'm not sure about other states, but in Texas, direct primary care providers, they are, the amount of services that they are providing has increased tremendously in the last couple of years as compared to a traditional model, because people have money, they can pay, and they want good service.
They want better quality of care. They're tired of getting this, subpar, meet you for 5 minutes kind of care.
And unfortunately, they have been waiting hours for that 15 minutes. So,
and specialists too. That's why so many, psychiatry. A lot of people go, especially for children, with their pediatrician for actual prescribing first, because to get in with a psychiatrist, it is darn near impossible within a month to be able to see them. So that's another delay of care. So I find a lot of conversations that I have with pediatricians a lot, especially when parents are trying to explore medications for whatever diagnosis we're looking at. They want more information because many times these kids haven't been on anything in their life. So this is very, very, very useful for that situation too, where let's say our pediatricians are versed on using mental health medications, but they're strongly going off of protocol and then trial and error. So this is a very big space that I feel like that's where we could get a lot of use and better management over these kids early on too.
That's true. That's true. I totally agree. And there are some of the providers who are willing to do that. Sometimes they're just, their hands are tied because of how the things run in the system. Even though sometimes
Right.
they have their own practices, they don't have that time. So
Mhm.
pharmacists can, kind of fill that gap because we are working as a team. There's no one's ego coming in. So because at the end of the day, we're working for what's best for our patients.
Absolutely. Well, I do want to kind of have a full circle moment here because thank you for so much for sharing your story today and just giving us some insight into how you're practicing, how you're utilizing precision medicine, and just what you're doing for the pharmacy practice in general as a whole. I applaud you in every facet that you're exploring and utilizing. But I'm really excited for our second part of this series. That way we can have a full circle moment collaboration meeting between yourself, Dr. Khan, and me on the next episode of this series. So that way we can get an MD's perspective on this kind of interaction and how it's been going. And I'm sure we'll hear rave reviews.
That sounds great, and I look forward to that conversation as well.
Perfect. Thank you so much for being on today's episode with me. And please, I encourage you to stay tuned for our next episode with Dr. Khan and Saba and the conversations surrounding how working with the pharmacist in the psychiatric space has been utilized, implemented, and used to the benefit of your patients. I'm very excited for that one to come. Thank you so much again for joining me.
Thank you, Melissa.